I'm going to talk about the aortic valve um, aspect of structural heart, and then Dr. Parik's going to talk about the mitral and tricuspid valves. So we have no disclosures. So hopefully we can help you understand the pathophysiology, symptoms, and the testing that we do for these valvular heart disease, and then understand the treatments that are available transcatheter now rather than open sternotomy, and then know how and when to refer patients to the structural heart team. So we came up with this idea of a structural heart division in cardiology, mostly because we now have some treatments that we can deliver without an open heart procedure, without an open sternotomy. And, it's not the same as angioplasties that we've been doing for 25, 30 years. So it's a little different area. So we came up with a new area called structural heart disease, mostly to treat valvular heart disease. There's a couple other things that can be done. Closure of ASDs, VSDs, patent foramen ovale. That's kind of a structural heart thing too, but that's fairly rare in adult cardiology. And then placement of Watchman, some people would put that under structural heart. That's a device to prevent embolization from AFib. So sometimes that's kind of lumped into the EP program, which is where ours kind of started. So we're going to talk about mostly just valvular heart disease, structural heart problems. So, why, I guess I'll talk a little bit about why do we have heart valves to begin with. So our heart's responsible for our circulation, for propelling the blood around your body. We didn't know that until William Harvey came up with the idea in the 1600s. Before that, they thought that, the liver produced the blood and the spleen consumed it. But that wouldn't work very well, because to have 5 liters of cardiac output every minute, you'd have to produce 100 kilograms of blood every 20 minutes. I mean, that's me, 100 kilograms, So that's really not possible. So figured out that there's circulation. Well, how does that circulation work? Well, your heart's mostly a muscle and squeezes the blood, but you have to have 4 one-way valves so the blood only goes one direction. So what can happen is when you get disease of your heart valves, so they're not working properly as one-way valves, you get shortness of breath because you start developing congestive heart failure, fatigued, eventually lightheadedness, dizziness, passing out episodes, and angina, chest pain. And in the case of the aortic valve, usually the progression is shortness of breath, angina, syncope, and then death. So pretty unusual for someone to die suddenly of aortic stenosis unless they've had an episode of syncope. But once a patient starts experiencing that symptom, then it's usually pretty critical that they get into the treatment phase of their disease quickly to prevent sudden cardiac death. So echocardiography has become the standard way to diagnose valvular heart disease. The nice thing about echocardiography is it's basically an ultrasound of the heart, right? So we're bouncing sound waves off the heart. We can do that repeatedly. We don't know any health risks to having sound waves bounced off your body, unlike x-rays. So it's very good for serial examinations over time. And so the criteria, usually the speed of blood flow across your aortic valve is 1 meter a second. So nice round number. And when your valve becomes narrowed usually from calcification. Your valve leaflets don't open properly. Then the blood has to accelerate to get across the valve, just like the nozzle at the end of a garden hose. You restrict the flow so the flow is faster. So when you have to accelerate your blood to about 4 meters per second across the valve, that's one criteria for saying, yes, you have severe aortic stenosis. Or if the pressure drop across the valve, because now you're going to have a drop in pressure because you put a restrictor in the line. When that drop of pressure is 40 millimeters of mercury, so the units we use to measure blood pressure. So your heart may have to generate a pressure of 160, so you can have a pressure of 120 in your arm. And then we can use a formula from physics to try to figure out, knowing the velocity across your valve, we can figure out what that area is that the fluid's going through. And when that gets to be smaller than a square centimeter, then we usually say that people have severe aortic stenosis. So sometimes these numbers, are on the borderline, and we look at all the numbers. We look at patients' symptoms and try to figure out, do you clinically really have severe aortic stenosis? So traditionally, the treatment for aortic stenosis has been surgery. There's really no medical therapy for it. There's no way to make your aortic valve better with medicines. You can kind of treat the symptoms, but you can't get the calcium back out of the valve and make the valve function better. So you need a mechanical solution. So traditionally, it's been surgical aortic valve replacement. So open up the chest and the heart. Surgeon cuts the old valve out and replaces it with an artificial valve, either a mechanical valve or a valve made out of tissue. Well, now we have a second possible intervention that we can do on the valve, and that is to perform a transcatheter aortic valve replacement. So instead of opening up the chest, we take a big catheter, put it up into the heart, put a new valve inside the native aortic valve, and basically expand that new valve inside the old valve. So we just push the old valve out of the way. I tell people we're like the snow plow. We don't get rid of the snow. We just throw it in the ditch. So you expand the new valve inside the old valve, and all that calcium in the old valve grabs hold of the new valve that we put in and doesn't allow it to move out of place. And inside that stent that we put inside the aortic valve is a new tissue valve made out of basically the same kind of tissue that has been used in surgical valve replacement for years. So I wouldn't say TAVR is a non-invasive really, but it's a minimally invasive surgical procedure to replace the valve. The first TAVR was done a little over 20 years ago in Europe. The first one done in the United States was done in 2005. So it's not a, technology that's been around for a long time. The first TAVR valves that were really commercially available, FDA approved, were approved for use in patients with high surgical risk. So patients that were deemed not candidates for a sternotomy. So the first few years of doing TAVR valves in the United States involved mostly older and very sick patients. Then the trials were done where younger, healthier patients were treated with transarterial aortic valve replacement, and it turns out there are less complications. The patients did better, a lot less morbidity to having a valve put in through a catheter. So the paradigm kind of shifted, seemed like almost overnight, where you were going to get a surgical valve unless you had an excuse to get a transcatheter valve. Now, basically, you get a transcatheter valve unless you have a reason that you need a surgical valve. Like if you're very young, so we don't want to put a biological valve in you. Maybe you want to have a mechanical valve that will last longer. Or if you have some other reason to have heart surgery, like you need an aneurysm repaired in your aorta, or you need bypass surgery at the same time. So that's one of the reasons in the workup that we do coronary angiography to see if people need a bypass operation. Okay. The other things we do is look at a dental evaluation, because patients who get endocarditis, that's usually from your mouth flora, and endocarditis is really devastating for a TAVR valve, because still a lot of the patients that get a TAVR valve aren't very good candidates for heart surgery, and not a very good candidate for a complicated heart operation like trying to explant an infected valve and fix that. We also look at the patient's frailty. We have some scoring that we can do for a risk score for patients to have heart surgery from the Society of Thoracic Surgeons. So you can look at a lot of factors like patients' kidney function, pulmonary function, ejection fraction, all these things, and put them in a formula and get an idea of what the risk is for heart surgery. And now there's been a risk formula developed for TAVR. But sometimes it really doesn't tell the whole story, because if you've got someone who, you walk in the room and you're like, wow, you look really bad. You're really frail. You look really old. You came in a wheelchair because you can't walk. I don't care what your STS score is. You're not having heart surgery. So, and sometimes we look at pulmonary function testing too, since one of the main problems people have is shortness of breath that brings them to us. We want to make sure their shortness of breath is really from their valve. So how the procedure is done: patient comes to pre-op, they go to the cath lab, we do the procedure there. We basically put in a big plastic tube up their leg and put the valve in across their diseased aortic valve, and most of the times we're using a balloon expandable valve. So we inflate a balloon, expand the valve, then we take all our catheters out and they go to recovery. Patients a lot of times stay one night in the hospital, sometimes two, as opposed to open heart surgery where you're in the hospital for 5 to 7 days. And most people are back to their usual activities, in a week. With a sternotomy, you're back to your usual activities maybe in 6 weeks. And minimal medications, little antiplatelet therapy, since you have a new device in your bloodstream. And this is an example of a valve. This is the self-expanding valve. So this valve is made out of a metal called nitinol that has an incredible memory. So you can change the shape of something made of nitinol, like put it into a catheter, and when you release it from the catheter, it goes back to the shape it was before. In fact, you could put something that's made of nitinol in a catheter for like 5 years and release it and go back to the shape it was before. And the other is a balloon inflatable valve. So those valves are made out of cobalt and chromium, I think. Metal alloy that has a lot of radial strength per volume. So we don't have to use a lot of metal. So that's what that valve looks like. Usually we see the patients a week following the procedure. 30 days, we do an echo, EKG, lab work. This all gets put in a registry for the FDA. And then we follow up usually in 6 months, and then in another year, And that data also goes to the registry. So long term, the FDA knows, was this really an effective treatment? Are we paying for something that's worthwhile? Okay. So now we're going to talk about the mitral valves.
Thank you, Dr. Olson. Thank you for having us. My name is Jay Parekh. I'm one of the interventional and structural cardiologists. I'm part of the structural heart team with Dr. Olson, Chuck, and Cindy and Rachel. I'll be talking briefly about mitral regurgitation and tricuspid regurgitation. So we discussed narrowing of heart valves with aortic stenosis. Now we're going to discuss leaky valves. So mitral valve is a valve which sits between the left upper and left lower chamber of the heart. And ideally, the valve is supposed to just open to allow blood to go from the left upper to the left lower chamber of the heart. There should technically not be any backflow of blood from the left lower to the left upper chamber of the heart. But because of various problems, the valve can be a problem. And there are two major ways how the valve can be leaky. One is whether the valve leaflets are a problem itself, and that causes leakiness of the valve and causes blood to leak back from the left lower chamber to the left upper chamber, which is called as primary mitral regurgitation, where the leaflets of the mitral valve are the problem itself. The second way how the valve can be leaky is where the valve itself is fine. The valve leaflets are working fine, but the top chamber or the bottom chamber on the left side of the heart is not working well. It could be because patients have had something called as cardiomyopathy, where the bottom left lower chamber of the heart, which is the main pumping chamber of the heart, gets weak, and it doesn't allow the blood to flow through the aortic valve and through the aorta, and all that blood starts leaking back across the mitral valve and goes into the left upper chamber of the heart, which is called a secondary mitral regurgitation, which basically means that the mitral valve leaflets are fine, but the top or the bottom chamber is not working well, which is causing increased pressures on the left side of the heart and causing the blood to flow back across the mitral valve. When patients have mitral regurgitation, if we don't do anything about it, they can develop symptoms, just like patients with aortic stenosis. And the usual symptoms are because there is so much backflow of blood in the left upper chamber, which accumulates around the lungs, patients can get shortness of breath. All that fluid can get accumulated in the legs. They can have swelling in the legs. They can have abdominal bloating, and they can be tired. We see patients in multiple age groups with mitral regurgitation. There are the primary mitral regurgitation, which is where the leaflets itself are the problem. We see a lot of young patients with that. And in those patients, we think whether open heart surgery is a better option rather than transcatheter. But we also see primary mitral regurgitation in a lot of old patients where the valve leaflets over years has become very redundant, and the valve itself stops functioning in a normal manner. And then we think whether transcatheter therapies are the right option for those patients. And then in secondary mitral regurgitation, where the valve leaflets are fine, but their top or bottom chambers are not working well, and then in those patients, MitraClip or transcatheter therapies are actually the first line instead of open heart surgery. So the way we diagnose aortic stenosis with an echocardiogram, it's the same test that we use to diagnose mitral regurgitation. We usually start out with a transthoracic echocardiogram, which is just using an ultrasound probe and looking at the surface of the heart and trying to see if there is a valve which is leaky or not. Once we have any indication of a leaky valve on the transthoracic echocardiogram, that is when we move to a procedure called as a transesophageal echocardiogram, which is just a camera that we use through the back of the throat. It's like getting an endoscopy done, but instead of the stomach, we're mainly focusing on the heart because we get much better resolution, very good images of the mitral valve with that procedure. And that procedure tells us how leaky the valve is and whether we can do something to fix that leak with catheters instead of going for open heart surgery or not. What are the treatment options that we have available? Everyone who comes with a leaky valve, as I mentioned, it can be a mechanical problem, which is primary mitral leak, where the leaflets itself are the problem. In those patients, usually medical therapy itself is not appropriate because there is a mechanical problem with the valve leaflets. So we usually have to do something to fix it, either with surgery or with the mitral clip procedure, which I will mention moving forward. And the second type, where the valve leaflets are fine, but the top or the bottom chamber is not fine. In those patients, we try everything to optimize their medications first and see if whether with medical therapy, that leakiness gets better or not. And we do see that in a lot of patients, just with medical therapy, that leakiness will get better once the squeeze of the heart gets better. After doing everything with medications, if the leak doesn't get better, then it's time to do something about the leak. The two main treatment options are open heart surgery, which was the mainstay of treatment probably around 10 years ago. But now we have more transcatheter options available for these patients who are high or even intermediate risk for surgery. And the main transcatheter option that we have available is something called as mitral TEER, which is mitral transcatheter edge-to-edge repair. What that means is basically we're using our catheters and trying to bring two leaflets of the mitral valve together with our catheters and with the device that we have available, which is called as a mitral clip. And I'll show a picture of the mitral clip as well. And we bring those two leaflets of the mitral valve together to decrease the leak around the mitral valve. It's a minimally invasive procedure. It is designed based on a traditional surgical procedure, which is called as an Alfieri stitch procedure, where the surgeon used to suture two leaflets of the valve together at the area where it was leaky to decrease the leak around the valve. And the same kind of concept has been used in transcatheter procedures, where with the two clip arms, we try to bring the two leaflets of the valve together and decrease the leak around the valve. And our goal in all patients is to try to decrease that leak from severe mitral regurgitation to at least mild to moderate mitral regurgitation. And this is how a clip looks like. So there are two devices which are FDA approved for a mitral TEER procedure, which is mitral transcatheter edge-to-edge repair. The first one is made by Abbott, and that device is called as a mitral clip procedure. And the second one is made by a company called as Edwards, and the device that they have is Edwards Pascal device, and they both do the same thing. They try to bring the two leaflets of the valve together at the spot where it is leaky and try to decrease the leak around the valve. The way we do these procedures, these patients come as an outpatient for the procedure. On the day of the procedure, the procedures are done under general anesthesia, where the patients are completely intubated and sedated for the procedure. Everyone gets a transesophageal echocardiogram at the time of the procedure to guide us during the procedure. And we go through the vein in the groin, because all the veins in the groin connect to the right side of the heart. So we put catheters in the right side of the heart and then cross over to the left side with our catheters and wires, and eventually introduce this device, the mitral clip device, into the left upper chamber of the heart and do a few maneuvers to try to steer down the clip across the mitral valve and eventually try to bring the two leaflets of the mitral valve together at the spot where it is very leaky. The procedure usually takes about 1 to 2 hours. It is a technically challenging procedure, but we are lucky that we have a great team of imagers who do a fantastic job with transesophageal echocardiogram during the procedure, and we have very experienced operators who are very comfortable with doing these procedures. So usually for us, it takes about 1 to 2 hours for doing these procedures. Most of these patients go home the next day. And the risk of any major vascular complication is significantly less because we are going through the vein and not the artery, compared to the aortic stenosis patients who, we're putting large bore catheters in the artery. Here we're going through the vein. So the risk of any major vascular complication is significantly less. And overall, this is a much safer procedure, even though very technically challenging, but much safer from a patient standpoint. The routine follow-up is everyone sees a structural nurse practitioner, Rachel, in 1 week. Everyone gets a 1-month follow-up with either me or Dr. Olson, and we'll do an echo and EKG at that time to see what the residual amount of leak is across the valve after we put the mitral clip or the Pascal device in. And then everyone gets a 6-month follow-up with a primary cardiologist and a 1-year follow-up with either me or Dr. Olson. And we'll again repeat an echocardiogram. And we tend to follow these patients very closely after the procedure, because it's not only the procedural aspect of the mitral clip, it's very meticulous post-procedural care, which is very important to get these patients a better outcome after the procedure. So we're constantly trying to tweak their medications, make sure that we do everything to prevent them from coming back to the hospital with heart failure. So it's very good medications and the mitral clip procedure which prevents these patients from coming back to the hospital with heart failure. Now, the mitral clip procedure, as I mentioned earlier, has probably been around for around 10 years. And then now moving on to the tricuspid leak procedure, it's called as the tricuspid clip, and it's designed with a similar intention like the mitral clip. Instead of the left-sided valve, we're now focusing on the right-sided valve. The device itself is again made by Abbott, and it has a very similar design to the mitral clip procedure, but instead of crossing over to the left side, we're mainly focusing on the right side. And this therapy, the tricuspid clip, which I will mention in a few slides, was first FDA approved in April of this year. So it's a very, very recent therapy. I was fortunate to be part of the first commercial case last year in training, and we hope to bring this therapy as the first center to do it in Omaha, hopefully early next year. So tricuspid regurgitation is basically leaky valves on the right side of the heart. Now, we discussed mitral valve, which is on the left side of the heart. The tricuspid valve sits between the right upper and right lower chamber of the heart. And that valve can again be leaky because of multiple reasons. Either the valve itself is a problem, or the top and the bottom chambers are a problem. Many patients end up getting a pacemaker. And the pacemaker, when we put the pacemaker, we can sometimes impinge on one of the leaflets of the tricuspid valve, and that can make the valve not close well, and that can cause a big leaky valve. And that can be very challenging to fix. Many times we can remove the pacemaker, put a micro device, and the leak gets better. But many times we have to do a tricuspid clip procedure in these patients to decrease the leak around the valve. Again, these are multiple causes of why a tricuspid valve can be leaky. And the two main divisions are whether the leaflets itself are a problem or the leaflets are fine, but the top and the bottom chambers are a problem. And this is the TriClip device. This is how it looks. It is modeled the same way like a mitral clip device. It has a few different knobs from an operator standpoint that we need to be aware of, but the device itself, it's a much safer procedure compared to a mitral clip procedure because we are no longer crossing over to the left side. We're staying on the right side of the heart. So that saves an extra step. It's very technically challenging to do because, the tricuspid valve anatomy is very complex. But again, as I mentioned, we have a great team of imagers and operators, and, we hope to be one of the first centers in Nebraska to do this. So when do we refer our patient to the structural team? If you see or hear anyone who has had an echo and it reads moderate to severe AS, moderate to severe mitral regurgitation, moderate to severe tricuspid regurgitation, and if you are unsure if now is the time to send your patient to the structural heart team, please send us a message. Cindy, Rachel, me, Dr. Olson, you can contact us anytime and we would be happy to review your case. These are our structural team members. Cindy just an amazing part of our team. Rachel, our structural nurse practitioner, Dr. Olson, and me. And please, this is our email, this is our contact number for the structural team. Please reach out to us. There are so many patients who are underdiagnosed with these heart conditions, and I think we have the resources and we have the team to help these patients. And we're happy to take any questions that you have.
Read an echo that shows fear on one of those things, wouldn't you probably contact me and say, is it okay if you see our patient? Would I have to be the one making the decision? Oh, I better send it.
You know, that's a great question. So I think because you are the one who's following the patient closely, many times it's not me or Dr. Olson reading those echocardiograms. It gets read by someone just reading echoes that day. So the follow-up aspect kind of gets missed many times. So the provider who's ordering the echo, and we're trying our best to kind of identify those patients based on the read of the echocardiogram, whether if an echo reads severe AS or severe MR, then you automatically approach you or the patient and try to set them up with the structural clinic. But we're still in the process of working those things out. So if the ordering provider, once they get the report saying that it's moderate or severe, then if you reach out to us, then that would be the best way.
I ask because on
Yes.
CTs of the chest, if they say, oh, there's nausea, would you like us to enroll them in the
Right.
program? They're
Right.
kind of on top of that radiologist.
Right. And we're working towards doing that. And our hope is within the next 2-3 months, we're working on an AI software where we will identify these patients based on what the read of the echocardiogram is. And as soon as the echocardiogram reads it's moderate to severe, then we will reach out to the ordering provider ourselves. But we're not there yet. So if you see yourself, then please reach out to us.
You might wonder, why not an artificial valve for the mitral valve? Why clip it? Why not just put in a new valve through a catheter? So the problem is the anatomy of the mitral valve is much more complex. The aortic valve, it's like putting a round peg in a round hole. Pretty easy. But the mitral valve has a much more complex annulus opening. So it's kind of oval instead of round, and it's actually kind of saddle shaped instead of flat. So it's almost like we'd have to make a valve just for each individual patient in order to do that. So my thought is maybe someday that'll happen. You do a CT scan and send it off, and somebody will make you a valve that fits just your heart and send it to the hospital, put in the catheter and put it in.
What's the duration? What's the lifespan of these things? I've seen people who had the old ball valve, mitral valves put in, many years ago, and they're still taking along. Do they know how long these are going to last before they're going to be replaced?
So with the TAVR valve, it's a little difficult because, up until late 2019, August of 2019, we could only use a valve in high-risk patients. A lot of those patients don't have a 5-year survival. So, but, our best probably estimate is this is a tissue valve, very much like the surgically implanted tissue valve. They probably have a lifespan of 12 to 15 years pretty safely, to say that. So we think our TAVR valves are going to last that long, around a little more than a decade probably. So, if patients are in their 70s, it's pretty straightforward to recommend a TAVR valve for them. You'll get them into their 80s, and when you have heart disease and you make it into your 80s, you're doing pretty well, right? For the clips, it's a little different between the two primary and secondary mitral valve situations because in primary mitral valve disease, the concern is you clip it. Well, if the valve continues to degenerate, you might have a problem in another 3 or 5 years or so. So that's probably why surgery, if you're a candidate for surgery, is still the first line therapy for that. People with secondary MR, mitral regurgitation, even with surgery, their life expectancy is not great. And if you can get them another 5 or 6 years with a clip, that's probably as good as you're doing with surgery. And that's why I think you would say that in secondary MR, surgery and clipping have very similar outcomes. But of course, there's a lot less morbidity in having a clip than having a sternotomy. So if the surgeons were here, I might be hit by something. But yeah.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.